In 2010, 2011, when the now previous government came into power in Myanmar, this is the same government that opened up Myanmar to the world. They set out on a series of key reforms, and one of the areas was in health. And so they created a roadmap for improving the health system and building the health system in Myanmar. And when I met with the then Deputy Minister of Health in Myanmar, one of the things she said to me, she said, "It's my dream to have a reproductive health logistics system." She was a true family planning advocate, and she knew that if there were no products, there would be no program, and Myanmar would not be able to achieve reproductive health and its key health goals without having a supply chain in place. And the people on this stage are with their vision and their leadership, help carry that dream into a reality. And so looking forward to hearing their perspectives and then having further conversation with you in the small tables. So without further ado, let me introduce them. On the far right here is Dr. Hnin Hnin Lwin. She is the Deputy Director of the Department of Maternal and Reproductive Health at the Ministry of Health and Sports. In the middle is Dr. Hla Hla Aye. She's the Assistant Representative for UNFPA Myanmar. And on the far left is Dr. Zar Ni Soe. He's the Senior Program Advisor for JSI in Myanmar. And the way we'll manage this panel is that Dr. Hnin Hnin Lwin is going to make a brief presentation and tell you the story and some of the background of the reproductive health logistics system in Myanmar. And then we'll ask the panelists to share some of their thoughts about the progress that's been made and the road forward. So thank you very much for your attention. As always, a collaborative effort. There we go, it's okay. So just use these arrows. Great.
Hello, good morning, everyone. First of all, thank you very much for letting us here and making presentation here. So let me tell you the story of Myanmar. So this is the very beginning of our journey. This is the first mile, and it was, we have to say, the strong commitment of our health officials and higher leaders that they want to have the strong supply chain system in Myanmar. This is our dreams come true. We could commit our family planning commitments in 2013, and this is the newsletter saying that we need better contraceptive supply chain and for RH commodities. And I have to say, this is where we are as last mile. They are now doing, reviewing the supply chain data. It is in our implementing township. This is Daungji Township, and with the township medical officer and his staff are reviewing the data as their routine work. And while they are processing for reviewing data, the light suddenly went out, and they continue with the candlelight, just showing their motivation. Yeah. And in 2011, during previous government time, we got the first budget line for our reproductive health commodities, which I've never got before. So for the first time during 2012 and 13, we got $1.3 million worth contraceptive for procurement. And in 2014, became double as 3.2 million, and in last year, we could procure contraceptives and maternal medicine for 2.8 million US dollar. And during 2013, we could conduct the baseline supply chain assessment. So there we found that there were few standardized systems and tools, and there are many parallel systems working by our partners. And at the same time, we began to align the system and process to get our implementing partners on board through system designing workshop, and we could develop the proper process and system for our country. And in 2014, we could start our trainings of LMIS system to basic health staff, especially midwives, who are working in sub-centers, who can be said as our frontiers and grassroots level staff at the rural area. So from 2014 and up to today, more than 2,000 health staff have already trained for RH LMI system. So this is one of the midwife expression. She said that doing well for the RHCLS means I got more products, so more patients come to my subcenter. And this is our electronic dashboard that we could develop with associated tools to capture information of our logistics system. And during that system, we could build the capacity and skills for states and regional level and central level as well. And one of the regional health officers said, the data in the automated system helps the difference between thinking and reality. I thought that male condoms were always overstocked, but now I see that stocks out in many facilities. So that electronic dashboard showed what happened in the reality, so she appreciated that. And so the midwives they are very interested and really enthusiastic for it. So they said that we can now see our consumption of products and be able to project when we will need for next month. So let me introduce that our quality improvement teams could develop in 2015 to review the data. So this is important because supply chain system in LMI system, we are not aiming to collecting and compiling the data. We need them to know, to review them, to analyze them, and to take action is also important. So we started that quality improvement teams in 6 townships. So there, among 12 pilot townships, we did quality improvement teams, QID, in 6 townships and not in 6 townships in order to compare them. In QID township, we found that more than 800 transfer of products could be done compared to 70 transfer only in non-QID townships. This is just their motivation platform that one of the staff saying in her Facebook, appreciating her junior staff who sent her their facility stock report and monthly report to her, although there was heavy rain and with some difficulties. So she appreciated them in her Facebook. In 2016, when we made assess a difference between the QID townships and non-QID townships, we found that it was definitely decrease for stock out in QID townships. So that's why our Ministry of Health and Sports, he decided to scale up that system nationally. And so let me show the map, and this is first pilot townships, 12 townships in 2013, and we scaled it up, and by the time of this year, we covered up to 55 townships. That means 2 states and region among 17 states and regions. So we hope that in 2018, we could cover the whole nation, which is 330 townships, including other essential medicines. So this is our partners, and UNFPA is the main supporting partners for family planning, as well as for this RH logistic management system. And other partners are Relief International, Pathfinder, Save the Children, and EU Commission. So let me conclude my presentation here, and thank you very much for your attention.
Thank you very much for those remarks. So now we'll go around and ask the panelists some questions about their experience and some of their insights, beginning with Zar Ni Soe at the end. Obviously, there's been tremendous progress for the reproductive health logistics system in Myanmar. Can you tell us what have been some of the most critical factors for the success thus far?
Thank you. So good morning, everyone. For your question, the reason why we have been now the stage of the success, so based on our experience, the one important point is the commitment of the people. So in this condition, the people means Ministry of Health and Sports. There are so many health staffs at the different level. For instance, like the basic health staff, especially midwife at the ground level, township medical officer at the township level, director and like assistant director at the state and regional level, and also like my colleague as a director, assistant director, and then some senior officer from the central level. So we are very lucky that when we start to implement the implementation of this system, so at that time, I'm very wondering that the commitment of the Ministry of Health of people has very, very strong enough to involve in our implementation system. I think it is I'm sure it is the most important point for the success sector. Another point is I should say the bottom-up approach. You know, I could also say that our system, how we start our system is a little bit different from the other project or other system. So when we start our system, for instance, like the system design development and then developing the procedure at that time, so we emphasize on the ground level. So that means like getting the inputs, recommendation, feedback, experience come from the ground level is the most important, rather than getting the idea or instruction or advice from the senior people from the central level. You know that. So actually, what I can say is what is happening for the supply chain management. What are the procedure, especially like the challenge of the supply chain procedure is at the ground level. You know, so that's why when we start developing our system, we try to get the inputs, recommendation, and the advice from the ground level. So the system now we develop is the completed with the requirements from the ground level. So this is the second important thing. And the third point is we took enough time to get a well-prepared plan, and then also that we take time for every activity. For instance, like when we conduct the training, you know, that we make sure that the training materials are very reliable and comfortable for the trainer. And then we also limit the number of the training, only for instance like the up to 25 people. And then we always make sure that the training material, especially like the trainee guideline and then trainee participant guideline, we make frequently the revision of the contents of the participant guide, training guide for the next trainee. So there are many success factors, but in this condition, I would like to highlight these 3 factors. Thank you.
Thank you, Zar Ni. And commitment has been a theme that we've talked about this morning, including in the Myanmar panel, and it sounds like it's not only commitment at the top, although that was critical to the success of the RH system, but throughout the system. And one way that you've been able to engage staff at different levels of the system is to use a user-centered approach and to iterate the system to respond to their needs and requirements and to give them a voice in what the system looks like. Thank you very much. Dr. Hla Hla Aye, we've talked about the tremendous progress that has been made in Myanmar, but I know it's not all been sunshine and roses. Could you please tell us a little bit about some of the challenges that you have encountered with the system?
Thank you, Comrade. Oh, okay. Thank you, Comrade. We have made progress, but then there are a lot of challenges. Myanmar is a big country. We have 330 townships, and then more than 1,200 facilities. So it's like more than 20,000 basic health staff to train. Right now, just as Dr. Hnin Hnin Lwin has said, we've trained 2,000 basic health staff. So there's a huge task ahead, and the commitment of the government and wanting to scale up is a very positive point. That is the challenge, and then the human resources for health. You would be surprised that the JSI's commitment and their technical expertise is a big plus. We did this with the country office with 4 national staff and only 1 international staff. And in the ministry also, at the central level, there's not much staff also. So overall, the health workforce of Myanmar now needs a real review, and then the government is heading towards human resources for health assessment, and then strategic planning, operational planning. So all these are the gaps that we have to overcome. And then, of course, the funding gap. The program is labor intensive. We're training people, we're building the system, and the people are most important in the system. And when we train people, we make sure that there is quality, so that the quality improvement teams are formed as an internal control kind of they are leading the system, they feed back to each other and make sure that the quality is there. So in that kind of a system, it is so important that we support them, and the funding gap for the program as well as the commodities is still prevailing in our country. In addition to that, the population of Myanmar is like 51.4 million right now. 70% of the population lives in rural areas, and we have 135 ethnic groups with diverse languages. So once we scale up, it's going to be a lot of diversity that we will be facing, the language as well as the different development stages. You see that sometimes the electricity goes out, and in the big cities there is internet connection. So building a system with a forward-looking vision is that one day we will rapidly grow to have internet all over the country, but at the same time, taking into account that there are some places we still use the paper base, and then we transport it into the township level. So these are some of the challenges that we're going to face.
Great, thank you. So there's no quick fix, like they said in the video, right? And we're at the beginning of this journey and moving forward, and we have to address the diversity, right, of the different interests and people and infrastructure, and have a system that's able to accommodate all those requirements. Great, thank you. Dr. Hnin Hnin Lwin, many of us have been watching with interest the elections and the transition of government that happened in April 2016. And I was wondering whether you could give us a sense of the government's continued commitment to reproductive health and supply chain, and what you anticipate the trends might be in support.
Thank you, Kamit. Yes, surely a new government committed for family planning and reproductive health a lot. And in this year, 2016, 31st May, we could conduct a high-level advocacy meeting for family planning to our new minister and parliamentarians. So in this advocacy meeting, we got a very high commitment from our minister as well to allocate more budget on our reproductive health, to strengthen the supply chain, and to procure more products for the security of reproductive health commodities. And our new minister is also very eager to promote the MNCH care, school health, and other continuum of care like adolescent health care. So he is very active and very optimistic person, and surely so there is no doubt new government and the minister they are going to have their commitment. Yeah, thank you.
Great, thank you. Zar Ni, the government has approved the scale-up of the reproductive health system, and all three of you have been moving that effort forward. If you could tell us a little bit about what are some of the key factors, key lessons that you've learned from the beginning of the process of scaling up this system.
Thank you, Kamit. So by taking this opportunity, you know that based on our experience, that I have some recommendation to some of you, or maybe more or less the same situation in some other country. That the most important things, for instance, like for our case, is establishing the system. So at the time, you know, I have some experience that the donor want to provide the particular support to address a particular gap. So in this condition, donor gives us some idea and then push the particular country to do something. You know that. So in our case, it is a difference that you know that. So when we start the implementation of our system, you know that we emphasize based on the ground level. So I will say the ground level. That means the people-centered approach. People mean the people who are working, who have to manage the supply chain procedure at the ground level. It is most important. That means, so when we develop the system, you know, that's almost all the inputs and then the procedure come from the people who are working at the ground level. I think it is a very important. So in conclusion, for instance, like it should not be the donor driving, or maybe the one organization driving. So another recommendation I would like to share is we are building the system. So, but that means that we are training the people. So training means in our country is not only for providing the training for a particular subject, but also we are now training them to change their mind about the way of thinking for the supply chain data, reviewing the data and the information. Because in our country, the basic health staff are used to work with a situation where there is a no stock, you know, the overstock. So previously, they understand that it is not their concern. You know that they have no worry about out of stock or overstock. Now, when we are providing the training, at that time we also try to mobilize them that this is your concern, this is your duty. Whenever you have some stock out condition or overstock condition. So even though we are providing the training, we also have to mobilize, and then we try to change their attitude to get some right thing for the data collection, data reviewing, and then also applying the data, and then to make the appropriate decision for the addressing the gap. So this is my second point. And then the last point, I think is in our project. So that means that we are establishing the system for the Ministry of Health. That means every step of the implementation, we always follow up the quality assurance. So in Dr. Hnin Hnin Lwin presentation, you know that we have one component as the quality improvement team. So actually, it is a very simple, you know, that we create an opportunity to gather at the one place from the different people. For instance, like the ground level midwife, and also township level, township medical officer, and then state and regional level, assistant director or deputy director from the state and regional level, and then sometimes also the director or deputy director level from the central level come together and then take only the 45 minutes to review together the data related to the RH commodity status, and then based on that, within just like the 30 minutes or 45 minutes, definitely we receive the follow-up action, decision for the follow-up action, and then we take appropriately. So I think that the quality assurance in our project we call the quality improvement team approach is very, very important for us. So thank you.
Great. And that's another theme that we've heard this morning is that building systems really means building people, right? And empowering them to have a role in the system, empowering them to make decisions based on data, and giving them the tools they need to be advocates and participants in the system. Great, thank you. Dr. Hnin Hnin Lwin, Beth reminded us of the 4 pillars of the Reproductive Health Supplies Coalition this morning. Availability and equity are among them. And when we look at recent data, we've seen disparities in use and unmet demand for family planning, and that coincides with some of the challenges we have in getting products to the last mile. Can you talk to us about how this system addresses some of those challenges and how the ministry is addressing some of those challenges more broadly?
Yes, as we have mentioned before, since 70% of our population reside in rural area, and we have the same geographical barrier, like we have the hilly regions, we have the delta regions, etc. So we have some kind of barriers and challenges. So equity in accessibility and availability, and access to commodity is a big challenge for our people. To overcome this barrier and challenges, we are now going with the approach of collaborating with our existing community-based organizations, networks like youth networks and civil society networks, and new now ethnic health organizations. And together with them, we are going with the strategies for provision of services and provision of commodities to reach to the most vulnerable population, such as poor people, urban poor, people in rural area, people in crisis area, etc. So this is our now new strategy. We are going to reach those vulnerable population and to have more equitable accessibility. And in this RH LMI system, we also designed the special approach to reach hard-to-reach health facility by provision of commodities, then other facility, etc. like this. So we have to think of for those such kinds of our barriers to overcome. Yeah, thank you.
Great. So it sounds like you've made some programmatic changes to ensure greater access to those populations, as well as changes to the system to ensure that those facilities that are further away, that are harder to reach, have different procedures, more supplies until the truck is able to reach
Sure,
them.
yes, yes.
Great.
Some, they are, the roads are very difficult to go, like
Yeah.
this, yeah.
Okay, great, thank you. Dr. Hla Hla Aye, last question. We have just 4 short years to reach the FB 2020 goal. I know that each day seems shorter as we near that timeline. What can we do to accelerate progress to meet those goals in Myanmar?
Yeah, we have only 4 years to go to meet the Family Planning 2020 targets, which are quite ambitious, like improving contraceptive prevalence rate from 40 to 60% and unmet need from 19% to less than 10%. However, I'm confident because we have such young and young professionals on the helm, and then with our partners together, we can accelerate. The first thing is to get commodities at the last mile. This means that we need to expand. The government is committed to expand the system. For us as UNFPA JSI, we depend on each other and the government. To expand the system, we need to fill the funding gaps. Number 2, even if we have the commodities at the last mile, the community needs to use our services. We need to mobilize the community. And coming here has opened our minds a lot, and we thank you so much for inviting. Young people represent 28%, 15 to 24 years, 28% of our whole population. They are the strength, and then we're focusing, investing in them for sexual and reproductive health and rights. And these people can be advocates for them, and they're very active. The next thing is that coming here, we've discovered a lot that there are ways and means to overcome our barriers. The GFF, Myanmar, maybe, will be one of the countries, I hope so. And then we're already geared up together, all of us. We feel that we will make sure that family planning is positioned as part of the RMNCH platform. So with all these kind of data that is available, Myanmar going through transition, people becoming more open, people changing their mindset, and data is power. And then in Myanmar right now, we have HMIS, LMIS in its starting stage. If we expand, we have the needy survey, the health facility surveys, PMA 20, if they come, we'll have more data, and then we can show that we have accelerated, we've put up more commitment inside, investing in our young people, investing in our communities. I'm sure Family Planning 2020 goals can be met if all of you are with us.
I think you summarized it better than I ever could have. And I want to thank you for your continued commitment to this cause. You are all such wonderful advocates and implementers of this system, and we look forward to expanding the community behind this effort to include those in this room. So thank you very much for traveling all this way, for sharing this experience with us today, and we look forward to continued conversations.
Thank you very much, Harmeet. Thank you.